Hi, it's Dr. Adam Stewart here, family doctor, and I just thought I'd bring your attention to another example of family medicine or family doctors getting dumped on by other people's work. I actually wrote this article called "Family Medicine is a Dumping Ground for Other People's Work" back in 2023, and you can check it out on my blog here. It's under my website in blog section. But it basically summarizes how too often family doctors are getting dumped on by work that is supposed to be included by the work of specialists in their own consults and visits. So check that article out. I've gone into a lot of detail there. Furthermore, the CPSO actually has a policy that relates to this, the continuity of care policy. And it says things like, for managing tests, for example, any physician who determines that the test is needed is responsible for doing it and managing it. In terms of, consultant physicians will need to provide the appropriate follow-up care and handle any administrative work stemming from this care. So basically, any work that stems from a consult, the specialist is responsible for doing. More specifically, to this example, who is responsible for referring patients to subspecialists? In most cases, the consultant physician, rather than the referring physician, is responsible for making the referral if they determine necessary. So, with that in mind, I have a patient who I just taken on recently, very complex, followed by multiple specialists for a mixture of cardiology issues and gastrointestinal issues. And um, basically, there's a balance between the need for a patient like this being on a blood thinner, but also needing to balance if the patient has a history of bleeding from the bowels that that maybe that patient shouldn't be on a blood thinner. So it's pros and cons. So again, I'm new to this patient's care. I'm just becoming the family doctor, whereas these specialists have followed the patient for over a year. And I get this note from a cardiologist who, in summary says, buries this. This is buried in the body of a big letter too. I strongly recommend that Dr. Stewart contact the GI team to determine whether there is a formal perlite, I think this is a dictation error, but contraindication for the use of blood thinners in this patient, basically. And if the patient has started on anticoagulation, please let us know. So, again, just taking this all into context of, the family medicine dumping ground, how specialists are responsible for doing this, I feel that not pushing back on something like this is being complicit in this growing crisis. So, here is a letter that I will be sending in reply, and I'll post it. But I'm basically saying, thank you for your letter, and just a recap of the patient's complexity and complex beyond the expertise of family doctors, hence the need to refer to specialists. I reference my family medicine dumping ground article and also the CPSO's continuity of care policy. And then with this in mind, I draw attention to that line that says, I strongly recommend that Dr. Stewart do this work. And I point out that the orders, quote unquote orders, may contain certain medical legal implications for family doctors like this because they can get buried in notes and they're inconspicuous and they will get missed. In any case, I point out the burning crisis and that I would be complicit if I did not push back. So highlighting the fact that communicating, referring with the patient's gastroenterologist here is part of the cardiologist's responsibilities required by the OHIP consultation fee code that would be billed. Also, per the CPSO policies that I just highlighted for you at the start of the video. And to be very clear, this issue at hand has to do with blood thinners arising from the need of a patient's arrhythmia. So it is certainly within the scope of the cardiologist here. But most importantly, it is in the patient's best interest of care here, undoubtedly, that the cardiologist and the gastroenterologist communicate directly to weigh the benefits and risks here and not have to use the family doctor as a middle person and not have to put this extra administrative burden and time on the family doctor just to be a middle person between the two specialists who should be communicating. So in any case, I push back. It's a little bit tongue-in-cheek here, but sorry. I strongly recommend that the doctor communicate directly with this other doctor, the gastroenterologist, to discuss the risks and benefits. I'm using the same phrasing that was used on me, so I'm putting that back on that doctor. And to please keep me as the family doctor informed of the ultimate decisions and plans. Thank you for the care of our, because he said at the end of his consult, thank you for the care of your patient. No, thank you for the care of our mutual patient.